Okay, great. Thanks everyone, and thank you for logging on today to participate in this webinar. My name's Natalie Happenstall. I got a lovely introduction just then, so hopefully you know enough about me to rely on the guidance that I'm going to provide you just now. This presentation is about knowing your code and tips from the Standards Advice team on how to know it better and how to move forward with that. So, if we get started, a bit about the code and its background. So the current codes came into force in April 2012 following a lengthy public consultation. We set up a working party here at the RCVS to make sure that all the stakeholders' views were taken into consideration, making sure that vets and VNs all had their voices heard. And they replaced the guides to professional conduct. Now the guides, for those of you who don't remember, had evolved into huge unwieldy documents. They hadn't really gone along with the changing kind of framework for regulation generally. So the way that professional regulation has gone has been towards a more principles-based system of regulation. And so we had decided to move with the times and move forward with that. Because we needed to adapt to that changing face of regulation, we needed to set out principles of practice. And there are 5 set out in the codes, 5 principles of practice to be maintained by all vets and VNs. And they are professional competence, honesty and integrity, which is perhaps the most crucial one, I would say, that kind of underpins everything that you do. Independence and impartiality, client confidentiality and trust, and professional accountability. So because of those principles of practice, the codes are very short. All the principles are pervasive throughout your practice, and they're subdivided into responsibilities that you have as a practitioner towards different groups. So that's responsibilities to your colleagues, to the wider profession, the public, the RCVS, your clients, perhaps most importantly, the animals. They outline your core responsibilities. So it's what a vet or a nurse must do. An example of a code principle is veterinary surgeons must provide veterinary care that is appropriate and adequate. That sounds fairly general, but it means it can be applied to many varied circumstances arising in practice. So what amounts to appropriate and adequate veterinary care might be very difficult in a critical small animal case to a routine equine case, for example. They're broad so that you can adapt them and work within them without being unduly limited in your sphere of practice. And it's these principles of the code that are the yardsticks that your conduct is measured against. So if, for example, the unfortunate situation arose where a complaint was made about you, and it may not happen, and even if it does, we can talk about why that's not something to be unduly worried about later. But if you feel that you have breached one of these in some way, or a client feels that you breached one of these in some way, it's important to remember that it's not a rule book. So because you've maybe acted in contravention of one of these principles doesn't mean that you're going to be sent to disciplinary committee. Alongside the code, we have the supporting guidance. So because the codes are so short and principles based, we have drafted supporting guidance to go alongside it to set out what you should do, not what you must, but what you should. They're designed to elaborate on the general principles of the code, but you should read both in tandem with each other. One doesn't really make sense without the other. They're intended to provide further advice on the proper standards of professional conduct and how to put them into practice. So, for example, we've elaborated on the principles set out in the previous slide, i.e. appropriate and adequate veterinary care, in chapter 2 of our supporting guidance, which is entitled Veterinary Care. One of the paragraphs in that chapter talks about how veterinary surgeons and veterinary nurses should facilitate the safe transfer of patients between veterinary practices, including outside normal working hours. So that's the kind of information that you can find in the supporting guidance. It's not intended to be prescriptive, but more of a guideline of what would be considered good professional practice. But that's obviously if it applies to the area that you're working in. We wouldn't expect you to take into account, for example, the guidance in relation to limited service providers and out of hours care if you are not a limited service provider. The chapters also have a role to play in managing the public's expectations in relation to their visits to the veterinary practice and their interactions with vets and VNs and the use of veterinary services. It may not be an in-person interaction, it might be an interaction on social media, for example, and we do have social media guidance as part of the supporting guidance, but it helps to set, and manage expectations of users of the service. So we also provide advice on the standards, as the standards and advice team. Kind of goes with the territory, you might have guessed by the name, but we do review the supporting guidance on a regular basis, and we do that to reflect current practice and legislation, to make sure that everything is taken into consideration, to make sure that we are adapting and evolving along with the veterinary profession, which, as we know, is constantly changing. So changes can come about not just because of changes in practice or legislation, but changes in relation to major policy issues or matters raised with us by the profession or any stakeholders or RCVS committees. So, for example, Chapter 3 of our supporting guidance, which is about 24-hour emergency first aid and pain relief, was reviewed following a lot of interest in a disciplinary committee hearing on the same subject. And we raised a consultation, and we looked into the profession's views more generally on that, and took a decision after having all that feedback from the profession. The vet care chapter that we mentioned before as well was expanded in certain areas because of complaints, concerns that had reached the RCVS preliminary investigation committee. And we took the view that further clarity on that subject would be useful to prevent further concerns being raised, to prevent other veterinary surgeons from finding themselves perhaps making similar mistakes. We've also got the telemedicine consultation currently ongoing. That's a good example of the supporting guidance and the code being reviewed and revisited. You may or may not be aware that telemedicine services are being commonly used in the human medical field at the moment and are becoming more and more in use every single day. There are providers out there that are wanting to facilitate the same for the veterinary world, and before obviously we compose any guidance on those, we would want to know what the profession think. And so again, we've issued a consultation. We've had a great number of responses to that, and we will be formulating our guidance based on the opinions of the profession. And we do receive regular advice requests generally about the standards from the profession and the public, and how these apply, how the standards apply in practice. So I would say we receive about 2,000 written queries per year, which for a small team keeps us pretty busy. We also get a lot of questions by telephone, and you can contact us by phone as well. For now, I'm going to hand over to my colleague Beth to talk about a bit more about the advice we can give.
Okay, hi there everybody. So the sort of things that we are happy to talk to you about, whether that be on the phone or via email. Certainly things around how to interpret the code and guidance for your specific situations. So, for example, if you run a limited service provider, like a vaccination clinic, the out-of-hours service that you need to provide will be different from that of a general practice or a referral centre, so we can certainly advise this. We also, a lot of the time, provide reassurance in relation to potentially difficult decisions. And we do understand that it's easy to second guess oneself in these sort of difficult situations, because maybe you have a tricky client or in a very poor condition.
Hi, Beth.
We understand that sometimes you don't want to hear that that what you're doing is not something that we're likely to be concerned about.
Hi Beth, I'm really sorry to interrupt, it's Stacey. I'm afraid since we've changed speakers, the sound quality has dropped quite significantly. I'm not sure of the setup in your room, but is it possible to use Natalie's headset and computer? Would that be okay? If you could just talk through your second bullet point again, and we'll just see. Sorry about this.
No, that's no problem. So we often provide reassurance in relation to difficult decisions, and this can be maybe a tricky client or an animal in a bad condition, and we know how easy it is to second guess yourself, and we're happy to sort of talk that through with you, and we understand that sometimes you want to hear that what you're doing is something that we're unlikely to take an issue with, and we're happy to provide that reassurance. So the other things that we can help with are implementation of good or better professional practice. So this could be, for example, in relation to clinical records. Perhaps you're struggling to get them from another practice, or you yourself are not sure about sending records onto a practice when a client has an outstanding bill, and we can certainly advise you on this. We also then talk about best practice, especially in difficult situations. And we know it's easy to forget things, but we always want to encourage you to make detailed clinical notes or ask the opinion of another vet to endorse your decision if that's applicable. We're happy to be sort of a sounding board in those situations to make sure that the simple things that can sometimes get missed aren't, and to make sure every base is covered. Certainly that ever comes back in the future, we want to make sure you've done everything you could have done.
Hi Beth, sorry, it's Stacey again. The sound quality has improved slightly, but it's quite echoey now. I can't quite see from our end. Everyone else is muted, which is good. But is there any other adjustments that could be made? We could hear Natalie perfectly.
Let's just try and fix this. Hang on.
Yeah, and Natalie, I can hear you perfectly then.
Oh, I'm wearing Beth's headset.
Is it the position in the room?
Maybe. Do you want to switch?
Sure.
I'm sorry about this, everyone.
Now at all?
That is so much better. Thank you very much for that, Beth.
That's so
Sorry for musical chairs in your office. I'll let you carry on now. Thanks.
That's all right. So we were talking about implementation of good or better professional practice. So we're happy to make sure every base is covered in sort of the difficult decisions that you're making. So if you ever need to give us a call about those sort of things, then we're happy to talk them through, certainly, because we know that there is potential for a concern to be raised against you in the future, and we want to make sure that every base is covered. We're also happy to talk about working with other members of the veterinary team. So this could be in relation to delegation to RVNs or SVNs and lay staff, for example. And we also commonly talk about what to do if you think someone's breaking the law. So that could be a breach of the Veterinary Surgeons Act. We can advise on how to pursue that and who to contact, as well as potentially giving a warning to the person in some circumstances for first-time offenders. Okay, so moving on to advice that we can't give. We can't give legal advice about employment or contractual disputes. This one comes up quite a lot, and unfortunately we're not able to advise on those sorts of things. But for employment advice, you can go to ACAS, and for things like health and safety, certainly you can go to the Health and Safety Executive, and they should be able to advise you accordingly. And there's always your indemnity insurer. If you need to have some specific legal advice, they can often provide that through their helplines. We're also unable to provide clinical advice or a second opinion. This one comes up more commonly when we get calls from members of the public, sometimes from the profession as well. And also, we won't really tell you what to do, but we will support you in making the decision. A lot of the time we'll ask you what the decision is that you want to make, and we'll sort of talk it through with you to see whether that would be plausible and within the code. We're not going to give you permission to do something such as breaching client confidentiality, but we will outline the things that the level that you need to reach and the sort of justification that you need to reach, and hopefully be able to reassure you in that decision. And so moving on to some frequently asked questions that we get. So a lot of the time it's to do with how to apply Schedule 3 of the Veterinary Surgeons Act, and also things to do with medicines. And Natalie is now going to talk to you about Schedule 3.
Thank you, Beth. Okay, Beth is right, certainly, in saying that Schedule 3 is one of the most common queries that we get. I would say maybe 5 to 10 queries a day that we get just on what it is, how to apply it, and how to move forward with it. So Schedule 3 of the Veterinary Surgeons Act, for those of you who don't know, is the exemption of the Veterinary Surgeons Act which allows registered or student veterinary nurses to carry out limited acts of veterinary surgery when they are employed and when they are under that employer's direction or supervision. The Act says, that Schedule 3 of the Veterinary Surgeons Act says that the caveat upon that, the limited acts of veterinary surgery can only constitute medical treatment or minor surgery not involving entry into a body cavity. That's, again, very broad, like a lot of the guidance that we offer is very broad. It's not always clear how it applies in practice, and so people get in touch with us to ask whether a particular situation would be appropriate to delegate to a veterinary nurse or a student veterinary nurse, or maybe we'll get veterinary nurses contacting us with questions about what their employer will want them to do. It's important to note as well that it does not apply to lay members of staff. So no matter how much experience they have, and no matter how much they've been doing in practice previously, or no matter what their job title is, or what alternative qualifications they might have obtained, it doesn't apply to them. So lay members of staff in practice do not benefit from the Schedule 3 exemption, and therefore do not have a legal entitlement to undertake any acts of veterinary surgery. Having said that, Schedule 3 doesn't mean that registered veterinary nurses and student veterinary nurses have the automatic right to undertake medical treatment and minor surgery. Schedule 3 gives the vet, the employing vet, I mean, we say the employing vet, but it really means the vet under whose supervision they are, who they're working for, who they're working under. It gives that vet the opportunity to delegate a particular duty if they see fit. And whether or not they see fit will be based on their judgment in that particular situation. So because a VN might have done a lot of assistance with anaesthesia, for example, at a previous practice, it does not mean he or she can automatically do so at their new practice. We set out in Chapter 18 of the supporting guidance, which is entitled Delegation to Veterinary Nurses. It's quite comprehensive. I would suggest you have a read through if you haven't already. But certainly in 18.7 of that chapter, we set out things that a veterinary surgeon should take into consideration when deciding whether it's appropriate to delegate something under the Schedule 3 exemption. So we've got that up there. I'll just read through it for you all now. In considering whether to direct a veterinary nurse or student veterinary nurse to carry out Schedule 3 procedures, a veterinary surgeon must consider how difficult the procedure is in light of any associated risks, whether the nurse is qualified to treat the species concerned, understands the associated risks, and has the necessary experience and good sense to react appropriately if any problem should arise. The veterinary surgeon must also be sure that he or she will be available to answer any call for assistance, and finally, should be satisfied that the nurse feels capable of carrying out the procedure competently and successfully. That last point is quite a crucial one. It really isn't just a vet's responsibility. It's a vet's responsibility to know their veterinary nurses and to have that conversation with their veterinary nurses to make sure that they're not putting undue pressure on them to do something that they don't feel comfortable with. So obviously it says that in Chapter 18 of the supporting guidance, but what kind of things are vets really going to take into consideration when they're thinking about delegation to a veterinary nurse? So the registered veterinary nurse or student veterinary nurse's competence. For example, competence does not necessarily include, or not only include, years of post-qualification experience and level of academic qualification, but also experience and competence of dealing with a particular species. So if you've got a veterinary nurse at your practice that is highly experienced in working with small animals, but you're not sure whether to delegate something avian to them because they have no avian experience, it may be something to think about not doing if they've not got much of a background in that area. Have that conversation and see what you're all happy with. The complexity of the case. If a case is particularly complex or there's greater potential for something to go wrong, the vet should consider whether delegation would be appropriate in the circumstances. Same would apply if an animal is particularly unwell, difficult to handle, behavioural problems, something like that, or is higher risk, i.e. it has an infectious disease or it's a chronic illness, it's its reactions to something might be particularly unpredictable and therefore perhaps not appropriate to delegate. You should also consider any further legal limitations on what can be delegated. So there are some limitations on medical treatment and minor surgery that are specifically set out in Schedule 3 of the Veterinary Surgeons Act. So an example of that is that an RVN or student VN is not permitted to spay or castrate a dog or a cat, or desnud a turkey, which I'm sure you'll all be very disappointed to hear. Desnudding a turkey is something that is limited to veterinary surgeons only. And then any expressed preferences of the client. So if a client's particularly difficult, you might want to ensure that the task isn't delegated to someone particularly junior, or if the client, for example, will need their animals' vaccinations to be certified, for example, for the purposes of a pet passport, then a veterinary surgeon would need to either administer or physically, at least physically witness the administration of the vaccination to be able to certify that. So having regards to your client's circumstances is also important when deciding to delegate. This is not an exhaustive list. So vets may have other reasons for deciding to delegate or deciding not to delegate to an RVN or student VN. If you're an RVN or student VN yourself who is in a position where you're not sure what you should be allowed to do, or you don't think that your vet is properly taking these things into consideration, if you're able to have a conversation with them, I would encourage you to do so. Have that two-way dialogue going and make sure everyone's happy with what's being delegated and what's not. But if you're still having issues, give us a ring and we can help you talk through that, and we can hopefully provide you with a supportive ear, if nothing else, and some guidance on how you might want to work with that.
Natalie, can I just add in to reiterate what you've just said there? I think it's a very common situation, as you've just said, that people are uncertain about delegation to veterinary nurses. For me, the summary is there are two decisions here to be made. A veterinary surgeon is going to make a professional judgment on the circumstances and ask themselves, can they delegate this to the veterinary nurse? Do I feel the nurse is competent to do it, and is it appropriate legally to do it? And then to reiterate what you've just said, the veterinary nurse themselves, they're professionals and they have to be comfortable that they are legally allowed to do it and that they are competent to do it. So I think that just is what seems a very complex area is actually quite a straightforward area. The veterinary surgeon has to make a judgment and the nurse has to make a judgment. And if everybody's comfortable that they're competent to do it, they're familiar with it, and it's within the legal framework of what a veterinary nurse is allowed to do, then it can be delegated.
Yeah, that's right. I would agree with that, David. I mean, perhaps setting it out like this has made it look a bit more complex than it actually is. But certainly a lot of these considerations will be second nature to you if you're working in practice. You'll be thinking about this kind of thing all the time. But as long as it is, as David has said, a kind of two-way process, you've got both sets of professionals, the veterinary surgeons and the veterinary nurses, making decisions and working together, that's absolutely fine. So to move on and provide a couple of examples of things that may be delegated under Schedule 3, and I emphasise the may because obviously it's not obligatory. Second vaccinations. I had a question about second vaccinations from a veterinary practice just this morning, in fact, and whether RVNs or student VNs could do them. There is some guidance set out in Chapter 18 of the supporting guidance about second vaccinations and about veterinary nurses undertaking them. Now, provided that the second vaccination is pre-authorised by the vet at the time of the first vaccination, all dealings can be, going forward for the second vaccination, can be undertaken by the registered veterinary nurse or the student veterinary nurse. The exception there is if it needs to be, the vaccination needs to be certified for the purposes of a pet passport, like I said in the previous slide. Certification is something that only veterinary surgeons can do, and therefore, if your client wants their vaccination to be certified, you would need to either have a vet do it or have a vet physically witness the vaccination being undertaken. Maintenance and monitoring of anaesthesia is another one. Again, this is a bit more information is set out about this in Chapter 18. It's quite a tricky area because there are some things that can be done by VNs, some things that can't. And generally, whilst monitoring of anaesthesia is the responsibility of the veterinary surgeon, it can be delegated to a suitably trained person. So vets, if you think your VNs are suitably trained to do that, go forth and prosper and let them do it. Similarly with maintenance of anaesthesia, provided it doesn't involve any acts of veterinary surgery, as long as it's just kind of acting as the veterinary surgeon's hands, then they can participate in that way. They can move dials, that kind of thing.
Just to add to that one again, Natalie, that means that the veterinary surgeon is responsible for anaesthesia at all times, but there are aspects of the anaesthesia that may be delegated to a veterinary nurse, but a veterinary surgeon would always remain responsible for the anaesthesia.
That's right, and that's why it's so important that the veterinary surgeon makes that decision to delegate in each individual case, because they need to be happy, they need to be confident that the person that they're delegating to is happy doing it and is competent doing it. Another thing to bring up in relation to this is that whilst a veterinary nurse can technically administer anaesthesia as long as it is a fixed quantity of medicine, they are not permitted to induce anaesthesia by administration to effect. So propofol, for example, is a common query that we get. Can veterinary nurses administer to effect using propofol? No, they cannot, because it involves them making a clinical decision about how much and when to stop and all that kind of thing that they are not legally permitted to make. Routine dental hygiene work is another example of something that may be delegated under Schedule 3. A lot of veterinary nurses will advise on dental care and things like that as part of nurse clinics, and we've no problem with their undertaking brushing if a client finds it difficult, or anything non-invasive. Certainly we wouldn't expect them to remove teeth with instruments, and for example anything involving instruments or drilling or anything like that would be outside the remit of the veterinary nurse. They could remove teeth digitally, however, if it's particularly loose, and give a bit of a prod, and they can get it out that way. IV catheterization and injections, something that is taught as part of the day one competencies for VNs and student VNs. So it's a good job that they can do them, really, but certainly it's something that may be delegated under Schedule 3, but cannot be delegated, interestingly, to a lay member of staff. And that's a distinction that a lot of practices and veterinary surgeons often have trouble drawing, is the difference between what a veterinary nurse is able to do and what a lay member of staff is able to do. And we've said previously and continue to say that anything IV, anything intramuscular is not appropriate for a lay member of staff to be undertaking, but may be okay for a VN to undertake under Schedule 3 if the veterinary surgeon feels that's appropriate. I'll give you a couple of examples of stuff that should never be delegated under Schedule 3 now. So this is stuff that is off limits to veterinary nurses and definitely lay staff, but certainly veterinary nurses as well. So this is just the domain of the veterinary surgeon. And some of these we have had queries about before. So I think it's important to clarify that these things are outside the remit of being delegatable, is that a word? It is now, under Schedule 3. So as I said before, specifically in the legislation, it's mentioned that a VN can't do cat or dog castrations or spays. Cystocentesis, they can't do that either. That's because it involves entry into a body cavity, i.e. penetrating the abdominal wall. Same for percutaneous gastrocentesis. It's not a possibility for VNs to do, far too invasive to fall within the definition of medical treatment and minor surgery. And intraosseous injections, because the bone cavity is indeed a body cavity, and therefore it can't be delegated under Schedule 3.
If I may just put a bit of context to this, currently people may be aware that there's a consultation going on about Schedule 3. So what we're talking about today is very much the legal status as it is today. This is as it stands. You may have been involved in that consultation. That is much more forward thinking, and Royal College is also undertaking an exercise to say at some point in the future, if the appropriate legislation changes can be made, we are looking at what roles veterinary nurses may perform. But just to reiterate, the current status is absolutely as we're describing today, and it remains to be seen what the future looks like as that unfolds.
Okay, thanks for that, David. So it's Beth again. I'm back to talk to you about frequently asked questions that we get about medicines. So one of the most common things that we talk about is the under the care requirement. And the other things are registration of practice premises and witnessing destruction of controlled drug stock. So if we go through these one by one. So the under the care requirement is something that's under the VMRs. So in order to prescribe a prescription-only medicine, POMV, an animal must be under the care of a veterinary surgeon. And so under the care is not defined in the regulations, but the college has interpreted it to mean that the animal or the herd, if the herd exemption applies, has been seen either immediately before the prescription or recently enough or often enough to have personal knowledge of the animal or herd's condition and to make a diagnosis and prescribe. So we don't really go into this too much. It's very much a clinical decision for you to make.
It might be very useful with this area. What does under our care mean? Each of our specialist divisions have dedicated quite a lot of time to this. So an animal under their care, what that definition looks like, has been well described by, for example, BSAVA for small animals. It's been well described by the Cattle Veterinary Association, Pig Veterinary Association. So there are industry guidelines out there on what under their care means. There is no one prescriptive model that works for all situations, and we have that sort of jurisdiction, if you will, as a profession to be able to interpret that as we think is sensible.
Yeah, indeed. It's often a question we get asked, but as David said, it's very much a personal decision by the vet, especially as whether you've seen the animal recently enough depends on the individual case, because as you can imagine, we can't describe for every eventuality that may come up, and that's where we do expect you to use your clinical knowledge. Certainly, as some animals you may be happy to see relatively infrequently, and others need more frequent consultations, and obviously depending on what it is you're prescribing for them. But there is certainly one thing that's for sure, that is, if you've never physically examined a particular animal or herd, you cannot really be said to have it under your care, and therefore cannot prescribe for it. So this means, at the moment, vets cannot prescribe POMV medications via a telemedicine consultation alone. And as mentioned before, the telemedicine consultation that the college has run is currently being processed, and we'll see the result of that one when it comes through. So moving on to registration of veterinary practice premises. So this is all to do with the list that the RCVS holds and maintains on behalf of the VMD. And this relates to every building from which POMVs are supplied. And each one of them needs to be an RVPP. And the reason it says bricks and mortar means that it can't, for example, be a car. This certainly relates to mobile vets, which we'll get into in a second. So an RVPP doesn't have to be every location from where POMVs are administered, but it has to be linked to one. So this could be, for example, if you do a home visit, the client's home doesn't then have to be an RVPP. And also it could be in-store vaccination clinic. No drugs will be stored there, and they're just brought from the practice as necessary.
What I found useful to understand what a registered practice premises is recently, I was making some inquiries in my own organisation. a veterinary wholesaler, it will be illegal for them to deliver any medicines to a non-registered premises. So if you have a branch surgery and you want medicines delivering to that branch surgery, it will have to be a registered veterinary premises. If it quite literally is something that you take the medicines to from your main surgery on an as-needed basis, it may then not be necessarily a registered veterinary premises. Same interpretation for a car. You don't have a medicine delivery to your car, you have a medicine delivery to the practice premises, and then you would take them out in the car on an as-needed basis.
Yeah, absolutely right. And that links well to the next slide, which talks about mobile vets. So you can imagine mobile vets who need medication to do their job. They also need to have a bricks and mortar premises listed as an RVPP so that they can order and supply medicines. And in particular, for mobile vets, they often choose to register their home as an RVPP unless they're linked to a particular practice. But that would be completely fine, and it's a question that we do get a lot. So on to witnessing destruction of controlled drugs. So this one is very clear-cut answers, but we know that it's an area that can be one where you sort of require some reassurance to make sure that you are acting within the regulations and within the law in this one. So Schedule 2 controlled drugs, and those Schedule 3 and 4 drugs that have been prepared extemporaneously are legally required to have their destruction witnessed. So this applies to stock. So stock is unused, out of date, and part-use medicines that could have been used again, but it doesn't apply to waste medicines or residual medicines. So leftovers in a vial that would be unusable do not need to be witnessed. And a common question we get along these lines are, who can witness the destruction? So it could be a VMD inspector, it could be an RCVS PSS assessor. If you have one visiting or one in your area, you can contact them. You could use a controlled drugs liaison officer. The local police will have details, or you can go on the website of the Association of Police Controlled Drugs Liaison Officers, who break it down by county and can give you details of the one that will be local to you. And finally, it can be witnessed by a vet who is independent of the practice. And the most common question that we get around this is that we understand a lot of practices are corporates and are linked to each other. And it's a very relevant question to ask whether a vet from another corporate could witness your destruction. And the answer is, if you're really struggling to find somebody else, then it would be fine. But we would probably expect to see sort of evidence of you trying to find other people to witness it before using a vet from the same corporate, if that makes sense. Okay, I'll just pass you back to Natalie.
Thanks, Beth. So I just want to wrap things up for everyone now. We've talked a lot about the kind of advice that we give. We've talked a lot about the most frequently asked questions. What we haven't talked about is when and how to seek advice from us. So leave me, no query is too small and there are no silly questions. You can ask us absolutely anything to do with the code and supporting guidance, or in relation to professional practice, anything of that ilk, and we will try and answer it for you. A lot of the time we will be able to give you an answer over the phone. If your query is a bit more complex, we might not be able to, and do bear with us, but we will seek advice from relevant sources, we'll collate something and we'll get back to you. We're also more than happy to provide information in writing if you want to incorporate it into your practice protocols, or if you want to show it to other staff at your practice or similar. Contrary to popular belief, we are not part of the concerns investigation team, so you can all breathe out and add in those questions, knowing that you won't be judged by us. The concerns investigation team are completely separate to us. We don't feed information into them, so if you called us for advice, for example, or you email us for advice, we're not going to pass it over to those guys, even if you think you've done something wrong. or if you think you've made a mistake, please don't hesitate. Contact us. We're not going to grass you up through the complaints people. What we will do is offer you constructive advice on how to avoid perhaps making a similar mistake in the future, or how to implement some good clinical governance and make sure that errors are learned from in practice, and that everyone at the practice can benefit from learning. The advice we offer is impartial and confidential. So we don't really mind what level you're at your practice, whether you're an employee, whether you're a practice partner. We're going to give you all the same advice if you called up with the same query. So it's going to be the same across the board. We don't favour corporate practices. We don't favour independent practices. It really doesn't matter from what perspective you're getting in touch with us. And similarly, confidentiality-wise, it's between us and you. You call me, for example, I answer your query, we have a chat about something that's perhaps upsetting you in practice. Unless you want me to tell someone else about it, I won't. And like I said previously, you can get in touch with us via phone or email. So you might feel a bit more comfortable about writing things out, particularly if you're perhaps upset or emotional about something, or if it's a particularly technical query. Similarly, if you want to talk to us about something that you just need to get off your chest and perhaps it would be better expressed verbally, then give us a ring and we're happy to listen. So all that remains to be said is a big thank you to everyone for logging on today. I think we've got some questions waiting for us, but if you have any questions at all going forward or want to get in touch with us, as I said, please do take advantage of that. Please do contact us. Our email addresses are on this slide, both mine and Beth's. If you want to talk to David as well, you can get in touch with him via our email addresses. And yeah, thanks very much for participating. And I hope we've helped you with a couple of queries that you might have had, and to give a bit of context as to the work we do.
Thank you very much to all three of our speakers for your great webinar and providing, very importantly, further clarity on the RCVS code. So that's much appreciated. Thank you. Like Natalie said, we do have some questions submitted. If anyone else would like to submit some questions, please feel free to do that now. We've also provided a feedback survey that should have popped up in a new tab in your browser. We really enjoy reading your feedback, so if you could spare 30 seconds to complete that survey, that would be fantastic. Thank you. So moving on to your questions and comments. The first question we have, does an RVPP have to be built of bricks and mortar or equivalent?
Oh, sorry. Can you hear me still?
Yes.
There we go. Sorry, I started talking and I think I got myself on mute. So yes, an RVPP does have to be bricks or mortar or equivalent. So it has to be a freestanding building, if you like, or an actual building. As my colleague Beth said, it can't be a car, it can't be a van that provides mobile veterinary services. But like we said, the common solution in that is to register your home as a veterinary practice premises. And that doesn't mean that it has to be listed publicly in the register. So don't worry about that if you're not wanting people to know your address, know your home address. It doesn't have to be listed in the register, but you will have to register it as a registered veterinary practice premises if you are a mobile practitioner and you want to use medications of any kind.
Great, thank you, Natalie. We had a question that came in whilst you were talking about prescription-only medicines, and someone's asked, what about prescription food? Can anyone hand it out even if they haven't seen that animal?
What they would need to do is check whether it's a POMV. Most foods aren't POMV medications, aren't prescription only, or don't involve any prescription only medications. And so whilst a lot of diets are called prescription, inverted commas, diets, they're vet recommended or veterinary advised rather than prescription only. So they can be sold and dispensed by any member of staff at the practice.
Brill, thanks. This is a question that I actually popped up in my mind. When talking about destruction of a controlled drug, can a locum witness the destruction of a controlled drug?
No, they can't. We don't think that's appropriate because they are linked to the practice financially, in that they are being paid by that practice. So yeah, I mean, the only circumstances in which they could, if they were volunteering or something like that. But yeah, it wouldn't be appropriate for a locum to do it. Similarly, it wouldn't be appropriate for example, if a husband and wife veterinary surgeon are practicing from two different practices, you couldn't get your family member veterinary surgeon to witness that instruction either.
Great, thank you. Someone's asked, I presume that you only offer advice from Monday to Friday from 9 till 5 p.m. Is that right?
It is, unfortunately, as much as I and my colleagues, I'm sure we would like to be able to provide a 24-hour service. Unfortunately, we don't have the staffing levels to do that. But certainly, if that is something that is desired by the profession, do get in touch with us. I mean, we did at one point a couple of years ago, we did a trial of an extended advice line. I believe it was back in 2014. There wasn't the demand for the facility then. There wasn't the demand for the service, but we are certainly happy to reconsider doing that again if there is the appetite for it. But do bear in mind, you can always access the code and the supporting guidance on the RCVS website or via the code and supporting guidance app if you have a smartphone.
Thank you. We've had a request, please could we have your contact details? Hopefully you should be able to see both Natalie's and Beth's email addresses up on the slide now. Natalie or Beth, do you have a contact email address, telephone number as well, and that you'd be able to read out?
Yeah, of course. If I give you all my my direct line now, that's 0207 202 0757.
Great, thank you very much, Natalie. We've got a longer question here. Sometimes you're asked to authorise a repeat prescription for a patient you've never seen, but another colleague has, and has originally prescribed the medication for a chronic condition, for example. You feel uneasy about the length of time gone since the patient was seen by the other vet, but the other vet has not requested to see the patient again. What do you do?
Right, well, the important thing to remember in this kind of context is if you are being asked to authorise that repeat prescription, you are the one responsible for it. So you're the one whose name is going against dispensing it. So you need to bear that in mind if you feel uneasy, and certainly if you feel uneasy, there's usually a reason for that. You know, trust your gut sometimes. Discussing the situation with your colleague internally is a good idea. So sitting down and having that conversation with them and saying, I've had a request for this from client X. You haven't seen them in maybe 6 months to a year. Can you explain to me what the reasoning is behind that? It comes back to the undercare requirement, really. If you haven't seen an animal recently enough or often enough, even if your colleague hasn't seen the animal recently enough or often enough, to be able to have a good knowledge of that animal's condition and therefore diagnose and prescribe, you really need to be seeing the animal. I mean, certainly if your colleague hasn't seen the animal in a while and they didn't feel the need to see the animal again, maybe worth pointing out to them the undercare requirement and say, you know, advising them of what that means and having a conversation about it.
Thank you very much, Natalie. Another question about RVPP. Can it be a mobile home or similar?
No, it would need to be a permanent premises. It needs to be a fixed permanent premises. Okay,
thank you. We've got a comment here that's come in. Great informative webinar, so thank you very much for that.
Yeah, thank you. Glad to be of service.
Are you happy to continue taking questions?
Of course, yeah.
Yep. So another question, setting up IV fluids and drawing up injections, is this a Schedule 3 procedure or could an animal care assistant do it?
Okay, so setting up of IV fluids as in connecting the catheter and that kind of thing, or connecting the fluids to the catheter. The connecting of the fluids really shouldn't be done by an ACA, but certainly drawing up injections can be, provided that they be directed very thoroughly by the veterinary surgeon. So if you're directing a lay member of staff to draw up injections, you need to tell them exactly what they're drawing up, for exactly what purpose, exactly how much, and as the vet, again, you maintain responsibility. So you need to check that and make sure it's being done properly.
Thank you. Going back to destruction of controlled drugs, can a previously but not presently employed veterinary surgeon witness the destruction of controlled drugs?
I would say it depends on how recently they've been employed. So if they left your employer a couple of days ago or a couple of weeks ago, or they continue to perhaps advise your practice in some way or do some unpaid work for your practice in some way, wouldn't be appropriate. But if it's somebody that hasn't been employed for you for maybe a year or more, then use common sense. I think it's fine in those kind of situations where there's no residual relationship with the practice.
Great, thank you. So I would like to know, can you take the controlled drugs to be destroyed outside of the clinic, i.e. to a police station or a neighbouring willing vet clinic?
The difficulty there is that you are then transporting controlled drugs. So you have to think about, you know, how to transport them and what you need to do. So where you've got a lot of them in a practice, and certainly it may be a situation where you have more than you might be able to just put in your locked glove box in your car, then you need to think about how you're going to be able to transport them in accordance with the requirements. So make sure, you know, for example, if you're transporting them in cars or storing them in cars, they have to be in a locked glove box or a lockable bag or box. A normal bag, for example, in a locked car is not sufficient. And you have to think about how that transport would be justified if the car was stolen, for example, or if someone managed to get their hands on the box or bag of controlled drugs. So whilst it might be technically possible, you would have to have a real good justification for doing that, I think.
Thank you. Do you believe any small animal that hasn't been seen for 6 months is okay to be prescribed for anything other than wormers or flea products?
It's really not for me to say. I'm not a clinician myself, and I wouldn't want to pass clinical judgment without being suitably qualified to do so. Similarly, I think it really depends on situation and condition. I mean, David will probably back me up on this one. As a veterinary surgeon, you don't know how long you'll be happy to prescribe something for or in what circumstance until you see that animal.
Yeah.
Yeah, I think just backing up what Natalie said there, every circumstance is different. The veterinary surgeon, it's professional responsibility to make that judgment. There are no rules that say 90 days is okay, 91 days is not okay. It has to be a judgment based on individual circumstances. And in the unlikely event of a complaint being made, we would have to, as a veterinary surgeon, have to stand up in front of your peers and justify the judgment you made. And that is how it works.
Great, thank you very much, David, for your contribution as well. So I think the last question then, regarding under your care, I've come across instances where vets have refused to dispense further repeat prescriptions unless the client consents to blood tests as advised by them. To what extent do we have jurisdiction over this?
Well, I mean, that's a situation for the prescribing vet. If they want to monitor a particular pattern, for example, in the blood tests, or they feel that they need certain information from those blood tests to be sure that the medication that has been prescribed is appropriate and continues to be appropriate, that's that vet's prerogative. I mean, obviously, clinical opinion will vary from vet to vet, and just because, for example, you as a vet might not have the same opinion as your colleague down the road doesn't necessarily mean that it's wrong. And so you can have those different clinical opinions and still come to a good decision on an animal welfare basis. And I think David might have something to say about that as well.
Thank you, Natalie. I know I just said that was the last question, but one more has just snuck in. So I hope I'm okay to ask you this as well. Having just reported a client to trading standards and a puppy placed in quarantine kennels because I suspected it was illegally imported, I would welcome stronger guidance when doing this rather than being down to my clinical decision. So not really a question, more of a comment.
Okay, I mean, I think that's fair enough, and thank you for the feedback on that. I mean, in recent years, I believe it was some point last year, we did actually strengthen the guidance on illegal imports and reporting those to the authorities. It's difficult to say you can really rely on anything other than your clinical decision, because I appreciate it feels like a lot of weight being put on your shoulders, but certainly you're the one that's on the ground, and we will never know better about a situation than you will from the information that you have before you. So that's why you have to rely on a clinical decision sometimes, because you are the one seeing those physical signs in the animal. You are the one that has had those conversations with the clients. And whilst, like I say, we can guide you to make the right decision, we can't make it for you, and nor should we really, because, like I say, you're the practitioner with the best knowledge. Certainly, it is in chapter 14 of the supporting guidance, the strengthened information on reporting legal imports, that kind of thing. I believe it's 14.33 onwards. So please do have a read of that. I think it's really helpful. Obviously, I would, as I took a part in drafting it, but I would welcome any feedback on that. So please do have a look. Whoever asked that question, and if you've still got any residual concerns after you've had a read through that, get in touch.
Can I just say a couple of additional words about the guidance and the way guidance is created? I'm currently chairman of Standards Committee, and we meet 4 times a year, and we sit down and we look at their guidance and we review it, and if it needs updating, we do. And Standards Committee is made up of very experienced people who are delivering veterinary services for many years, either in practice, sometimes through the vet schools. We have a broad range of input into Standards Committee, and so there's a great deal of insight out there about what happens and what really goes on in the real world, and that's how our guidance notes are constructed. And then our advisory team here, they help put it into sort of sensible layout, very readable, very usable, and they're sort of using this guidance on a daily basis. But it is constantly being reviewed, constantly updated to reflect the circumstances of the real world. And so we hope that it is very practical, very useful for how the real world actually works.
Thank you very much, David. I just want to end, and there's lots of comments coming in saying thank you. One in particular says, excellent webinar, thank you very much. I hope there are more to come along the same lines. So I'd like to echo that by saying thank you again to Beth, Natalie and David for your presentation.
Thanks very much.
No problem. And also a big thank you to the RCVS for providing this webinar. It will be recorded, so you can go back onto the Webinar Vet website and watch it again to view the slides if you like. Thank you to all you attendees that submitted questions and were able to join us on the live webinar. It's always great to have your company and feedback. Apologies again for the blip in sound quality at the start of the webinar. And finally, thank you to Holly for co-hosting on the webinar with me today. We hope.
Can I just add one last thing? Sorry.
Yeah, of course.
Is that all right? I'd just like to say to anyone that might have asked a question as part of the webinar, but we haven't unfortunately had time to answer it, please do submit it to us via email or ring us up with it, and we will answer it for you. So any questions that you've submitted here that we haven't unfortunately had time to answer, ask them again directly to us, and we will answer them for you.
Thank you very much, Natalie. So I hope you can join us on another webinar soon, and I hope you all enjoy the rest of your day. Thank you.
Thank you very much. Bye, everyone.